The main problem with most of the cardiology patients are the patients of stable coronary artery disease. And these patients almost have exertional angina for a couple of months, maybe years, and they are on various drugs. So there are debates whether which drug is useful, which is not, and what is the role of angiography and angioplasty later on. The main concern is the use of drugs and how long it has to be used. All these patients most of them are young, less than 50 years of age, and initially they are on nitrates, whether you start with a short-acting nitrates or long-acting nitrates. The short-acting nitrates we usually give in acute episodes, but patients who has a stable coronary artery disease have mostly on the long-acting nitrates. The only problem with the nitrates is, the drug resistance and headache. So we can add, along with the nitrates, we can add the beta blockers, preferably a metoprolol. But unlike metoprolol, there are others, second line of drugs like ivabradine, ranolazine, and trimetazidine. And once these drugs does not work, then all these patients should be thoroughly investigated and sent for some further stress thallium or invasive measurements like coronary angiography, and to look for severity of the coronary artery disease. So, and then comes the role of statin, especially the high dose of statins, either rosuvastatin or atorvastatin, and then the role of antiplatelet in such situation. The initial we used to give clopidogrel 75 milligram once a day, but then newer generations antiplatelets like prasugrelol and ticagrelol, they are all also being used. So antiplatelets have a very useful role in prevention of plaque rupture, and it helps in improving the plaque stabilizations and reduction in the endothelial dysfunctions. Thank you so much.
Okay, good afternoon. I am Dr. Samin Sharma from CSI TV in Mumbai in the CSI conference. I'm a director of interventional cardiology at Mount Sinai Medical Center, and on my right side is Dr. Ashok Seth, who is the chairman and most expert interventionist of India, and on my left side is Dr. Upendra Kaul, who is now the director of cardiovascular center science at Batra Hospital. The purpose today is talk about the Indian stents, and I'm so privileged to share this dais with these two expert Indian interventionists, and will give you some glimpses of what is going on at present, where the Indian stents stand in many of the trials. So one of them, I would start with the talent trial, because the trial which really made a big headline. So Ashok, you were there at TCT in San Diego, and the talent trial was presented, and it actually, for our Indians, I am actually in America for 30 plus years, but I always, anything comes out from India really boosts my further enthusiasm and blood and the confidence. So there was big noise about the talent trial, and it was subsequently also covered by a lot of media. Can you just tell all our viewers here what it was all about and what was special about this particular stent, which I know was targeted against our most popular stent in the USA?
So you're right, Samin. I think it was a great day for India. There's no question. It was a pride to see the amount of exposure, the amount of publicity which and the amount of attention which India got from this important study. And it's rare when a large pivotal study gets presented on the main forum, on the late-breaking trials at the biggest meeting in the world, and a very scientifically done study. So it made us proud. It not just made us proud, because the stent is very good and that it lived up to the expectations of being a very good stent against a very powerful comparator. The comparator is considered the gold standard of stents at the moment. And our Indian stent, Supraflex, was randomized in a very prospective manner, in a very scientifically designed study, a multi-center prospective study done between Europe and England, and what it showed was non-inferiority. In fact, it showed that it was as good as the best in class of the drug-eluting stents which we've been using of the West for years. So that was one. The fact that it was a great study was the other one, and it made us proud to have such a stent. The fascinating aspect of the stent, by the way, I would still say that this was actually a second generation or a first generation stent of the company, and that also matched up to the best in class stent. Now we can imagine that at the moment we're using the next gen of that company, and it can only be performing better than the second gen stent that we actually use. So it was quite
remarkable.
Quite remarkable.
So, Dr. Upendra Kaul, I'm sure you used all the stents, Supraflex, and so tell us. We'll come back to the trial a little later. Your personal experience. You used the Supraflex in your clinical practice. You used Zymes and many others, Promus, Synergy, and so. So, how did you, before the trial came, the results came, what was your mindset and what is your feeling that how good the stent was it faring as good as, of course, there was not a label that was Americanly tested, tested in a randomized trial, but how was your feeling over the years on that stent?
Well, Supraflex has been one of the very good stents for many years. It first came into the market 7 years ago, and the beauty of the stent, it is ultra thin stent. You know, this is the time when we're talking of ultra thin stents. It's 60 microns. It is chromium cobalt. It has a biodegradable polymer, and its crossing profile is just 0.039. Zymes, the latest stent, the Zymes Sierra, now has matched its crossing profile of 0.039. And other thing is that the strut thickness of 60 microns is uniform. Small vessels, large vessels, up to 4 millimeter. The other small, this ultra thin stent is, as you know, Orsiro, which again is a very well acclaimed stent. It has gone through many studies like bioflow studies, has shown lower MIs because of low strut thickness, but between 3, 3.5 and 4 it becomes 80 millimicron. So that is the beauty of this stent. So we thought that having got a very good share in India, 11,000 to 12,000 Supraflex stents are used in India every month, and Zymes about 12,000. So it's very close. Other stents are other Indian stents like Yukon and Merrill stent. So we thought that we need to have a randomized study, because we have a registry of Supraflex with OCT and everything else in 250 patients, showing a very good nominal late loss and a good healing pattern. So we thought that it needs to be done in a prospective multicentric studies, and the most powerful part of the study was that it was all comers, acute MI, grafts, left mains, no exclusion criteria. So this was done in 1400 patients, and as you know, as Ashok said, it came out to be as equivalent with a 4% margin, of non-inferiority. It came as equivalent with the stent thrombosis of 0.5 or 0.6% in both. The device-oriented composite endpoints, which is the standard these days, was equivalent. So it fared so well that we have decided now to go in for a superiority study, which is the real thing. And we have also decided to go in diabetics, because if you know, the Freedom study against CABG was done with the first generation stents. It was Daxus and Cypher. Stents are not available, and we know the limitations of that. So that message that in all settings, in diabetics, surgery is better, this again has to be shown in a prospective study, and we're planning that also.
What is interesting about this is that the first in-human study was actually done with a stent called Supracore by myself, the first in-human study of 250 patients. Even at that time, and this is we're talking about now 10 years ago, 11 years ago, the results were amazing. For the first time I saw an Indian stent behaving dramatically, and we at that, again, that study was all comers. It was the first in-human study, and yet we were seeing no restenosis, and for the first time we are seeing long lesions, triple vessel disease, stented with this Supracore, and doing very well. So it's extremely promising, but it also suggests one more thing. Two things have come out from this. Firstly, that our devices are good. They just needed to be proven in a scientific manner, and that was very important. And the credibility mattered, not for this country, but it mattered across the world.
Yes.
The second is that this company was able to do an immaculate study against the best comparator, and that again is a first time, I would say, for an Indian stent. If we get more of this, and I believe that, I mean, we can generalize this as Indian stent, but I would say this Indian stent is particularly good. Now, are all Indian stents good? Probably they are, but they need to go through this sort of randomized study to actually, for us to be confident about their use in our patients, and for the world to be confident about the technology that India develops, which is of extremely high standard.
Other thing, Samin, is, as we all know, that the annual attrition rate after 1 year, after angioplasty, whatever stent you use, is 3% per year, which is alarmingly high. So one has to see what can be done to reduce it. One is a very good medical treatment so that the other parts of the vessel remain healthy. But what can be done to the stent? The best thing could be, because whether the stent is a biodegradable polymer stent or a stent with a durable polymer, and the science has shown that good durable polymers are very good, and sometimes they may be better because they always are thromboresistant layer there. But one thing is, their metal, if it remains in the vessel wall, is going to corrode, is going to leave ions, which can produce subtle, gentle inflammation, which can produce problems later. This was the direction for the BVS. Unfortunately, BVS had a problem. I still feel that that is the way to go about, although, 150, 160 microns is not the way to go. And in that direction also, I think everybody is trying that, although the process has become slow after Abbott, lost its heart with this very thick stents. So design matters. I think the design of the stent matters, and lower the strut thickness is good, but I don't think strut thickness can go
Beyond
less than 30, less than 60, because you need some radial strength, you need some pushability, you need some conformability. So that is the way to go. So I think the $1 million question is going to be, because science still has a lot of promise, because we're just showing non-inferiority. So we need to find out whether with a biodegradable polymer, a 60 micron stent will be equivalent to a 60 micron stent with a durable polymer. Both have to be equivalent, because if the thickness matters, then lower is better. So that is the way one possibly should go till the time we get back to metal goes away.
So look, talking about that, it is going to be extremely difficult in the present era for any stent to show superiority. All these stents have become so good. They are getting all thin struts, they are actually getting every aspect perfect. Yeah. We are into third generation devices. And I doubt that we'll ever be able to show superiority over one device over the other. And therefore, you're right, the TAC has to be totally different. And I do believe bioresorbable scaffolds still hold the biggest promise. Thinner struts and the design characteristics which are being changed are perhaps what we've been looking for, and there's no doubt the older needed to change into new. And that is going to be the future, the disappearing. But another aspect which I actually say is, even this, of non-inferiority of supraflex over Zynes is a huge thing, and I'll tell you why. It's huge, not just because it's non-inferior and it's an Indian stent. but cost now matters. So
Yeah.
what's the next differentiator for across the world? The next differentiator is if you've
going
got
to be cost.
equivalency, if it's as good, if it delivers well, and if it treats well, then why are we going to pay twice more for a different stent? And that is the things which needed to be proven. And I think that's one of the big steps forward.
Yeah.
Because if we can't change in the direction of results into superiority, then there is a superiority in it being less expensive. There is a superiority in the way it's been developed and made available. So, and it's a superiority in the way it can be available to the masses in the country. So I think that's the big step forward.
And this gives the confidence to the Indian operators, because many of us rightly had a feeling that the American stents and European stents started long back. This is a new stent. Just being patriotic doesn't make that much of an impact till the time you show that you're bloody very good. You're doing the same thing and cost effective. Although we have a stent price cap there, but Indian stents are able to get into the market with a little more margin than the American stents, and the Zion Sierra and all that are not going to come. So we need to improve the deliverability of these stents also now. Stent is good, but deliverability has to be improved. And in this trial, Talent, because I was the co-chairman, I have the details of the trial. One of the factors was there that the device success
Was lower.
was 97.5 versus close to
94.
99 in that. And one of the reasons was that, because this was a European trial, was that if you're not able to push it, they were going back to their familiar stent. Let us use our familiar stent. So that could also have affected that, because they didn't try to push it harder, because they said, why get into the trouble? We have another stent lying on the shelf. So, but all said and done, some of the things like shaft crack, kinking and other things have been worked out during the period of the trial also. So the next generation of the Supraflex stent is also focusing on how to make the delivery system slicker. And the newer generation stent, because everybody is getting into everolimus, so is a stent called Tetriflex, which is again 60 microns, but has everolimus as the drug, because everolimus is becoming more popular. Although I think sirolimus and everolimus doesn't make a difference. And we have done a 50 patient intravascular, the OCT study, and they've shown that at 3 months and 6 months, the healing is perfect. It is not 0.1, it is about 0.2, 0.3, which is very safe. And all the data analyzed by Alex Abizet in Brazil, and that gives much more and more confidence. So that's what I'm trying to say, that Indian stents have got into the milieu of testing it rigorously and showing it in publications and showing it to the world.
So let's
that is the way
let's
to go
hope
about
that
it.
this study gives an impetus for firstly more Indian stents, and there are good companies. We know that there are good companies who created good stents in India, other companies. Let's hope that this gives impetus and excitement to others to do such large-scale studies. We understand that it costs money. It's a huge investment, but that huge investment is for India's credibility, growth, research, science, as well as it would be obviously for the sales across the world. And the second aspect is that it gives impetus to the industry in the country itself.
Yeah.
After all, we're talking about made in India. And for us, that made in India is always going to be a pride.
Yeah.
India is one country which has survived on what's come from the West. In a way, yes, they survived because those were the proven stents. They'd done large studies, they had done long-term studies, they had done pivotal studies, and they had huge data. So there was nothing wrong in that. But now's the time for us to transform that, and that's the made in India spirit. I never want to believe, there's always one thing, okay, made in India cheeze use karo. And I say I never want to believe that what I put into me, I should be able to put into my patients what I would put into me. And unfortunately, unless we make our quality parameters so robust that we can rely, it is studies like this which will make us rely on what is being produced here. Because unfortunately, our quality parameters in this country are still not as uniformly robust as one would have liked it.
And it's very important to prove or disprove a hypothesis. Like Samin, you may be remembering that Taxus stent was still considered to be a good stent for diabetics based upon large meta-analysis of Greg Stone till the time we did the Tuxedo study and showed that everolimus stent was better there, and that was the demise of Taxus. And also in the talent study, the other thing which I'll say was a little shortcoming is that diabetics were 21% because that's the typical European population. We have diabetics as 35%. So we need to also see that it performs equally well in a diabetic patient population. So there are, many things we have got from the talent study, and it has given us the impetus. It's being published in Lancet. That again gives us a credibility that an Indian stent for the first time coming into the Lancet as a full paper. So I think the positives are many.
Clearly the excellent study done and by the Indian manufacturer. It's a pride for us, and more importantly that it was proven scientifically better. And since then further designs even have been made, as Dr. Seth pointed out, that these were the earlier generation, and of course the subsequently will even give rise to a better result. So with that note, we conclude our today's this discussion on the talent study, which used the Supraflex Indian-made sirolimus eluting stent against the top most commonly used stent Xience, and the device-related outcomes were identical, except the crossability procedural success was slightly lower, but that was by using the old generation stent. With that note, I hope you enjoyed this discussion, and wish you a very good evening, and enjoy the CSI conference and try to make a best use of it. Thank you.
Thank you, Samin.
Thank you very much.
I'm Dr. Karthikeyan. I'm Professor of Cardiology at All India Institute of Medical Sciences. And this is Professor P.P. Mohanan. He's from Westport Hospital in Thrissur. And he's a senior cardiologist who's done a lot of work on ACS in Kerala. So we will be talking to him about the Kerala ACS registry in particular, and some other aspects of the ACS scene in India, and how we can scale up what they've done in Kerala to the rest of the country. So,
thank you, Professor Karthikeyan, for this opportunity. When Kerala ACS registry is the largest ACS registry from India, and as we are aware, despite the grim statistics of cardiovascular disease in our country, we have very poor scientific research output. And that was one of the innovations that the Cardiological Society of India Kerala chapter has done, where we collaborated with about 125 hospitals in Kerala and brought out a registry of 25,753 patients with acute coronary syndrome. And what we saw also surprised us a little bit, in the sense that now we have a high STEMI mortality. The STEMI mortality was something to the tune of 8.4%, which is definitely higher than whatever is prevalent in the other part of the country. And this may be attributable to, one, of course, the delayed arrival of the patient with ACS, and then the paucity of the reperfusion, the timely reperfusion, and maybe some inappropriate therapy also. And possibly the most important thing was the underusage of guideline-directed medical treatment. So that made us learn quite a number of lessons, how to counter them, and how to sort of get over these inadequacies in the management of acute coronary syndrome.
I wanted to particularly ask you about the one, you mentioned that inappropriate therapies. For example, we have this a bunch of people with ACS, NSTE ACS who received thrombolytic therapy. So why do you think that happened? What was the...
I mean, basically, people have a notion, because you should know that out of the 125 hospitals, about 45 to 48% were managed by physicians. I'm not saying that is the root cause, but people have a notion that, well, whenever you have a thrombotic milieu, antithrombotic drugs or lytic drugs may be useful, but that may be one of the reasons that the physicians are also not really into the guideline-based therapy. So, which we could correct. We could, just like in the West, where they have shown that adherence to the guideline-based therapy through various methods, various trials, they have shown that if you improve by educating the physicians, by educating the paramedics, we can improve the results.
The other interesting thing about the Kerala ACS registry was that your time for STEMI, your time to reperfusion was about 5 hours, was it? So you've also published the access to reperfusion therapies in a separate paper. So I noticed that you said most patients in Kerala live within half an hour of a primary PCI lab. So why do you think there is this discrepancy?
Well, there is one definite reason in the sense. When we did the Kerala ACS registry, that was in 2007, 2009. The number of cath labs at that time was 26. While when we published the access registry, the rural, the setting of the park registry, the primary angioplasty registry, that was in 2016. And when we have 106 cath labs.
Okay.
So the privilege, the number of cath labs have significantly improved and possibly that is the one single reason. And of the lessons learned from the Kerala ACS registry also, I am sure, should have kept in their mind, because our rate of reperfusion, the lytic rate was 45% and the primary PCI was a meager 12%. While if you look at the Kerala, the ACS QUIC, the quality improvement data, reperfusion is 60 plus. So there's a tremendous improvement in the reperfusion strategy that is happening.
And what's the primary PCI rate in the quality improvement?
The quality improvement we have touched on to 50%.
That is excellent. So I think Kerala ACS group needs to be congratulated on what you've done, a pioneering bit of study in this country. I don't think anybody else, any other state, any other CSI, state CSI has managed to do this. So I wanted to ask you, what is it that makes the Kerala group special, so that we can learn from the Kerala group?
We always pride ourselves about the Kerala model. Now you would have heard about the Kerala model of the economic persistence and the surveillance. Same way, I think there is a Kerala model of cardiovascular research where the funding is taken care of by the Cardiological Society. So the investigators need not worry about how do I get the funding for this method. And the second part, there are some devoted groups of people, and mind you, they are not very much trained in any cardiovascular research. Now, I myself is not have a front like you. I didn't undergo any informal training. But then we have been involved in some of these clinical trials and multinational trials, and we wanted to do some legitimate research, because one of the things that we always say is, Indian research is of poor quality. We wanted to have a high quality research with meager reserves. So this, I will say, is a Kerala model where the funding is done by the own institution, your own maybe mother body, fine, if you can do that, fine. Then there are about groups of people, a state coordinator. For example, in Kerala ACS registry and in ACS Group, I was fortunate to be the coordinator. Then we have other collaborators. Each one of the cardiologists in Kerala now wanted to be part of the research program, and they have no hesitation to share their data.
So the other interesting thing, I realized that one of the most important things that is needed for doing research is an incentive for doing research. I mean, academic investigators, like in hospitals like ours, we have an academic incentive, so that is a given. But what about, so the large majority of your group are people who do private practice. So what is the incentive? What is it that drives you?
I think the once we started the Kerala ACS registry, and that sort of percolated an intense desire among our junior colleagues to be part of some scientific research program. And mind you, we did never pay any of the investigators any substantial sum. Whatever very meager sum that we paid was mainly used to continue the research activity. So I think it is the desire to be part of a research program which will be useful for our patients. And also, that started, now we have 7 registries running in Kerala. a primary PCI registry, a pulmonary hypertension registry, an atrial fibrillation registry, a vitamin K polymorphism registry. You name it, we are running it.
That's amazing. So before we close, I just wanted to get your insights on what do you think are the most important steps you must have seen in the ACS QUIP, which is a follow-up to your ACS registry. What is it that is needed to make at least the state of Kerala comparable to the West, say at least Europe, Western Europe, in terms of access to reperfusion therapies for STEMI? What is it? What are the few things that you think are important?
I mean, very, very important issue that you have brought in, because the systems of care of, especially the STEMI care in our country, is very meager. The systems of care should be there, that's for sure. But then the contribution of a cardiologist is, I will not say is minimal, but is limited. So the second part, that is one part. The second part will be the how to improve the adherence to the drugs that he should be getting. Every patient with ACS should be getting a list of drugs. So an admission discharge checklist and audit feedback. Now that is one of our success stories. We gave all this hospital every monthly an audit feedback report saying that this is the way that I am treating, this is my dual antiplatelet, this is my rate of primary PCI or my reperfusion rate. So, and also the other patient education material, all this matters. The systems of care is something which rapidly
Beyond the
merits.
scope of. But if I were to ask you only about improving access to reperfusion, you may not comment if you don't want to, but in adjacent Tamil Nadu, there is a push for doing pharmacoinvasive therapy. So what do you think about that? Is that a model which is scalable to the country, or?
Well, I'm not very certain. But if you ask me about Kerala, I mean, Kerala possibly may not be the best state to implement the pharmacoinvasive therapy, because already we have 126, and the areas where fibrinolytic therapy used, I will not say that it is irrelevant, but it is still relevant, but it is it may be relevant in certain situations, certain states where now the cath lab numbers, the sheer presence of a cath lab doesn't warranty the proper reperfusion. We have seen, even despite all these cath labs coming here, your balloon time may be still 4 hours, 3 hours. So what is the fun in that? So I will not say pharmacoinvasive therapy is suitable to every state in Kerala. I mean every state in India. It may be, it has its relevance. I'm not negating that.
One question about the number of you said more than 100 cath labs in Kerala. It's a small state, so high density of cath labs. So how many of these are private cath labs and how many of them are public cath labs?
I mean, now the government sector has tremendously improved. Earlier it was something like 2080. Now it's about 35, 65 or something. But you again makes another important issues. The mere presence of cath lab doesn't guarantee a 24/7 primary PCI service. Many of them has their limitations.
Plus also reimbursement issues. A lot of it might be out of pocket and patients might not want to.
Absolutely.
Is there also, I know that in some parts of India, patients who are sick, like STEMI patients are often, they are not treated with primary PCI because of the risk of, say, untoward events during the procedure, and then there is a backlash against the hospital. So that happens quite often in many parts of the country. So is that a deterrent to providing?
I mean, I will not say that will act as a deterrent, but then in a situation where a country like India, where even the healthcare delivery system is not properly instituted or maintained, we have to be careful in saying that, well, this system is the only one which is suitable for us. But as you rightly said, the primary PCI, all of us know, is the main thing which will save STEMI patients. There is definitely every state should try to implement as much as possibly that particular program. There is a role for pharmacoinvasive. Our bane will be the delayed presentation where we can only request the government and the policymakers to do something about that.
So finally, I'll try to ask you something which is probably in the realm of policy, but maybe you can, if you were asked by the policy apparatus in this country about what are the things that can be done to improve primary access to STEMI care in this country for the country as a whole. So what do you think should be our primary aim of focus?
I mean, our primary education, our primary policy should be educate our people. That's number one, because in a nation obsessed with, I will say, quote unquote, gas, every patient who has a chest discomfort has to realize that this could be a myocardial infarction and they have to reach a physician. I think that's the most important thing. All our developments in implementing the systems of care will be of waste if we don't educate our patients and tell them that this is the most important thing. I think that will come as the number one point apart from implementing the systems of care and implementing a quality improvement program.
And one final question I have to ask you, because you see, we are a large country, very educated medical professionals, but unfortunately our research output is not up to scratch. But you have made it happen in Kerala. So what would your advice be to the rest of the country, I mean other states, in order to be able to produce this kind of data? We have lots of potential, but we've never lived up to it. So what would your advice be?
I mean, learning from whatever little things, I will say we're not a great thing, but we have done something, and that is only because of the collaborative efforts of the people, of the cardiologists and physicians in Kerala. Every state possibly can emulate. If Kerala can do it, any other state can do it. What it requires is some certain leadership qualities of cardiologists who will try to collaborate with the youngsters and others who are very keen to involve in any research programs. And we don't pay them, we don't even involve them, mention them in the paper that we have read, but they are part of us. I think a collaborative effort of the cardiological group in our country will see that our research outputs improves substantially.
Thank you, Dr. Mohanan. That was very good talking to you, and I hope this will provide some incentive for people in the rest of the country to emulate what you have done, so that we can really produce good data to direct care.
Thank you very much.
Thank you. Thank you very much.
Hi everybody, friends and colleagues. I am Dr. Narayanan Nambudiri KK, working as a professor in the Institute of Sri Chitra Tirunal Medical Science and Technology in Trivandrum. I am sitting here in the capacity of editor-in-charge, editor-in-chief of Indian Pacing Electrophysiology Journal, the official journal of Indian Heart Rhythm Society. This journal is unique in many aspects in India. This is probably the first online open access journal from this subcontinent. In fact, this was founded in 2001 by Dr. Johnson Francis from Calicut. Initially, it was an open access journal for years, and within a couple of years of its inception, this has been taken in PubMed, that is PubMed Central. That is a database of US National Library of Medicine, and it has been available in PubMed Central since that time. It has also been indexed in Embassy Medica and also in Scopus and also Elsevier Science Direct platform. So it has got an international visibility, and in that aspect it is probably one of the few medical journals published from this country. Another interesting factor of this journal is that this one doesn't incur any other charges for publication, though it is free open access. And interestingly, with time, we have started receiving more and more articles across the world, and nearly 70% of the submissions now are from United States of America. It is a matter of pride for us. And for the last 4 years, the publishers has been Elsevier. It's an internationally acclaimed and probably the most popular publishers across the world. And more than that, this has been incorporated in Clinical Key, that is one of the database for Elsevier for the last 1 year. and it has been having regular publication issues for the nearly last 2 decades, and it comes every 2 months, and our speed of processing the manuscripts has shortened, that become faster quite significantly in the last 4-5 years. Now the processing speed is around 2 to 4 weeks, and the initial decision is made often in these submitted manuscripts within a few weeks, and it is available online as soon as it is published. There is a huge increase, significant increase in the number of downloads across the world in the last 4-5 years. In 2016, there had been more than 30,000 downloads of articles from our journal. And this year, it has been 60,000, and most of these downloads happened from United States of America. That is an important aspect. And I have been serving as the editor for the last 4 years. And we have 3 associate editors, all from different parts of the country. Now we have improved our editorial board strength, and we have 15 section editors, and of note, we have section editors ranging from Dr. Samuel Ashirvadam from Mayo Clinic, Dr. Adar Vail from Europe, and 12 out of 15 of these section editors are well acclaimed senior electrophysiologists who have got significant number of publications and high impact factor across the world. So we hope we will have more visibility in the near future, more submissions, and we also hope that we will have an impact factor in near future with Reuters, and we need help in form of contributions of important articles and also original articles, reviews, and every sort of contribution, academic contributions in near future from you all. Thank you. On behalf of Indian Heart Rhythm Society and also for the editorial team of Indian Pacing Electrophysiology Journal. Thank you.
Hello, I am Dr. Anil Saxena, President-elect of the Indian Heart Rhythm Society of India, that is IHRS. And with me I have Dr. Jitendra Makkar, who is the organizing secretary of our annual conference at Jaipur. So Indian Heart Rhythm Society is the main body that is basically formed by the rhythm experts in the country, the electrophysiologists who deal with the disorders of the cardiac rhythm. And with me we have Dr. Makkar. So Dr. Makkar, would you like to welcome the delegates to your conference at Jaipur?
Yeah, sure. So good evening everyone at CSI. I am Dr. Jitendra Makkar, and we are organizing 10th Annual Congress of Indian Heart Rhythm Society at Jaipur on 7th to 9th of December at Hotel Lalit, and we are here to invite you all to this beautiful gathering of people who are interested in electrophysiology and device and heart failure management, and who are doing good work in this field of cardiology. They all are invited, and this year IHRS will be little special because we have 2 combined sessions, one with the IHRS, combined session of IHRS with HRS, Heart Rhythm Society of America, and another combined symposium is with Asia Pacific HRS. So we are getting the office bearers of these societies as faculty member this time, and it will be beautiful to interact with them and take the Indian EP to next level with the interaction of Asia Pacific experts and the global experts. And secondly, also for young EPs we are having a fellow course, so I'll invite those who are undergoing their DM, DNB degrees and they have interest in electrophysiology. They can come get registered as fellow course, and they can have a nice opportunity to learn how to begin in the EP. And of course we also have a IBHRE mock examination. IBHRE certification is a very prestigious thing for any person who is working in EP. So we are conducting a mock examination so that a fellow or a cardiologist can get a primary idea that how to go about these examinations. So, and not to miss, Jaipur is a beautiful city. It's called Pink City of India, and December is very nice weather to be there. So I'll request all of you to get registered for Indian Heartburn Society meeting 2018, which is in Jaipur. So looking forward to having good times with all of you. And sir, Dr. Anil Saxena, as a president of you have been recently elected as president of IHRS. So any message you would like to give to our CSI members who are here, how to go about membership as well as this?
Yeah, thank you, Dr. I think one of the main messages is that we have a huge number of doctors who are taking care of heart rhythm disorders, whether it is by doing EP studies and catheter ablations or by implanting devices like pacemakers and defibrillators. And not all of them are members of Indian Heart Rhythm Society. So because we have so many activities going on both in terms of education and conferences, that it will be worthwhile to become a member of IHRS. So I will encourage those delegates who are involved in heart rhythm problems and dealing with those problems. I will encourage them to become members of Indian Heart Rhythm Society. And I wish you all a wonderful conference, and I hope you are enjoying it's a wonderful conference going on, and have the best of your time. Thank you so much.
Yeah, thank you so much. Thank you so much.
Good evening, everybody. It's a privilege to be here. At the outset, I'd like to thank the organizing committee of the CSI for holding such a wonderful program. The scientific sessions are absolutely stimulating. I am in my capacity as the convener of the Cardiac Rhythm Council. I've been privileged to be nominated by the CSI as a convener. So it's my brief to just outline the activities which we are planning in the next few months and what we have been doing for the past year or so. We have had ECG sessions, and the brief from the CSI to us is to increase ECG and arrhythmia awareness amongst the physicians, and I'm happy to report that we have had a couple of such meetings and they have been a tremendous success. So all congratulations to CSI for thinking about this initiative. And the next meeting which we are planning is the Cardiac Rhythm Council meeting, which is scheduled to be held in February next year on 16th and 17th. We hope to have a full house. We will update regularly about what is the scientific program going to be, and wholeheartedly seek your involvement and participation in the Cardiac Rhythm Council in the months to come. Thank you. Thank you.
Okay, good evening to you all. So, welcome to CSI TV. We are on wrap-up of day one. Now, before we go to the brass tacks of day one, let me take this opportunity to congratulate the organizers. Dr. Praful Kelkar, Dr. Amit Vora, I think
the entire team, because we initially had an apprehension. You are moving away from a hotel setup scenario, a convention center of a hotel, to a totally makeshift arrangement.
Absolutely.
So we thought that there will be some hiccups, but absolutely no hiccups. What a fantastic arrangement. I think all praises to Praful and his team. Air conditioning is fantastic. The seatings are good. It's an excellent environment for learning. Everything. We could not find any problem with this thing. And I think a makeshift arrangement is fantastic. They have done a wonderful job. So it's a very, very comfortable environment to learn, discuss and network.
so. A great first day, and probably the best ever first day in the history of CSI conferences. So there were 4 halls. Hall A dealt with the continuing medical education. Hall 2 was interventional cardiology. Hall 3 was pediatric and electrophysiology. Hall 4 was imaging and echocardiography.
Yeah, right.
And in addition to this, I was told that they had a live CPR session going on, teaching not only our postgraduates, but also the police and the fire force.
It's a part of the social commitment of the CSI.
Good. So,
What about the registrations? You have any idea about the 2 days registrations? Day
yes,
one?
we had fantastic registration numbers. Over 2,500 delegates registered today, and there were more than 30 foreign faculties.
And we were usually we are worried about whether there are adequate delegates in the halls or not. What is your feel on this thing?
The halls were full. In fact, there were people standing in Hall A and Hall B.
And the Hall B, I think I attended some of the sessions in the Hall B. It was full.
That's good.
It was full and active discussions going on.
So we are going to give you a snapshot now of what actually happened in Hall A. And I think the day began in Hall A with what they call as a new kids on the block. They discussed about newer drugs, newer therapies, and then subsequently when the controversies in cardiology. I think one of the controversies that I liked was the controversy when Dr. Survo Banerjee was asked this question: should angios be done in all patients with an acute myocardial infarction presenting after 3 days? And I think in his discussion, the OAT trial prevailed. And he reminded that the ESC guidelines give a class 3 recommendation in asymptomatic patients. And he quoted the CSI guidelines for acute myocardial infarction presenting after 72 hours. And it says that if there is symptoms like hypotension or arrhythmia, then they should be taken up to the intervention lab. And if it's asymptomatic, he stated that you must have some test for ischemia or viability before going into the lab.
It is not something like a blanket statement that after 72 hours you need not have to do anything in a completely occluded vessel. It depends upon the circumstances.
And then interestingly, subsequently, Dr. Wander discussed, vaccinations in cardiology.
Right.
And ACC gives a class 1 recommendation for vaccination in cardiovascular patients, while the ESC apparently gives a class 2B recommendation. So what are your viewpoints on this?
Because I have heard the heart failure talk, because there was an entire session on heart failure. There, even vaccination is a class 1 indication. The Haemophilus influenza vaccine as well as the pneumococcal vaccine, it's a class 1 indication now for heart failure patients. But for other cardiovascular diseases, and for that matter for diabetes is also, it's an indication now. So vaccination is coming up.
To quote him, he said, as physicians, it's our duty to give the flu shot and the pneumococcal vaccine, especially in diabetics and heart failure patients. What was your take on the heart failure session that took place in the afternoon?
The heart failure session was fantastic because they moved from the basics of the heart failure treatment, the guideline directed management, up to the use of LVAD or mechanical cardiac support as either a destination therapy or as a bridge to transplant or a bridge to decision. Many things. For example, the most important thing I think they have discussed is one regarding the iron deficiency, because that is one area where it is neglected. 30 to 50% of the patients will have iron deficiency, and iron deficiency is not equated with anemia. There are 30% of the patients who may have iron deficiency without anemia, and it's our duty to look for iron deficiency, looking at the transferrin saturation, whether